Hopefully, yep, it looks like our webinar has started online. So for those who are joining online, welcome. We're going to take, like I said, another 3 to 4 minutes and just let folks come in. You'll notice a QR code on the screen here. We have some questions throughout the presentation. We'd love your input and participation. So if you don't mind, please take a chance to scan that so that we can get your input throughout the session. And we'll be starting shortly.
Sorry, do you know how to make a full screen for the presenters online? It's not showing up full screen on Zoom. They have like one of them.
Oh, I don't know. No. It's still not showing up full screen?
Not all the way full screen.
Okay, otherwise we could extend.
I think that's fine actually.
It's fine. Okay. Cool. You can go to this one.
That's fine. There we go. I see we're getting some thumbs up from our online participants. All right. So as a question, just to kind of get us all started, I would like for all of us to think about, what do we hope to get out of this session? What would make this session a success? And as a reminder, we are going to be talking today about assessing and addressing the specific pathways of infection in children under the age of 2. And with that, we really want to understand from sort of a broad-based perspective what's being done, what's in the works. And so we'll have for you a few examples of that, folks presenting. And then following that, we'll be taking a deep dive to really look into some of the more intricacies and details of a project that are addressing these pathways. Excellent. So I see here that folks are really interested in the findings, working to improve collaboration across the space, discover success examples of actions to reduce pathogen exposure, and what works in household hygiene. We'll take a couple of more minutes for those to come in. You can see them popping up on the screen here. And again, if you've just gotten here, if you scan the QR code that we have showing here, you'll be able to participate and share your input. So just another minute or two. We're so tight, I'm going to try to do it at 8:35 sharp. I see folks are interested in truly transformational WASH, as well as new approaches. Yes, to learn from others on what's being done and address pathogen exposure. All right, please keep those comments and input coming in. We really do appreciate them. For now, I'm going to go ahead and move us through so that we can get started. And again, today we have a number of folks from across multiple organizations who will be presenting here, including Pro Wash and Scale, USAID WASHPaLS 2 with FHI 360 and World Vision, London School, Food for the Hungry, Innovations for Poverty Action, Kenya Medical Research Institute, UC Berkeley, North Carolina State University, Malawi University of Business and Applied Sciences, University of Strathclyde, Aquaya, ADRA, and Save the Children. So quite a list of participants here. We're very excited to have them with us today. So what we have for your agenda, of course, we do want to start off, certainly with not only our welcome, but we would like for you all to kind of level set the room. And with that, we'll have a review of the current state of evidence. Following that, we will have a question and discussion session. And then after that, we plan to have that sort of broad-based overview looking at applying research within WASH programming. That will also be followed with a Q&A session. And then after that, we'll talk about sort of, discussion on the way forward, and then we'll close out for the day. So without any further ado, I'd like to pass it over to, our objectives. So today's objectives, what do we hope to really get out of this session? In addition to what folks were sharing earlier, we hope to discuss the roots of pathogen exposure, and in particular, look at those that are specific to infants and young children. We want to recount the range of innovations currently being evaluated for feasibility and potential impact on child growth and development. We'd like to identify research or programming gaps that organizations may then be able to fill. We would like to access new resources and contacts to support the evidence-based research, build on that collaboration, and understand where some of those resources may currently be. The outcomes, we hope to disseminate the current best practices and innovations, and to facilitate better coordination among stakeholders, including intervention specialists, scientists, donors, all of these important actors who are leading to new research and new intervention activities to address the growth of infants and young children. And so with no further ado, I'm going to turn it over to Amy Pickering to talk about the current state of the evidence.
Hi everyone, good morning. Thanks for coming to our Friday session. I see everyone's looking like very excited at the end of the conference. So I'm just going to talk a little bit about, summarizing the last 5 or 6 decades of evidence in 5 minutes. Okay, so how do I advance this? Oh, there we go. Okay, so I wanted to start out by just talking about this great series of papers that just came out in Nature that took 50,000 observations of longitudinal data of children from low and middle income countries and looked at when stunting happens for these young children, and also some of the factors that are associated with stunting incidents. So what this is showing you is child age on the x-axis, and on the y-axis, incidence of stunting. And so what you can see is that stunting is happening either in the prenatal period or in really early time in these kids' lives. So between 0 and 3 months is when we see most of stunting happen. And this is another really interesting finding from the series of papers, which is showing how wasting coincides with seasonal rainfall. So you can see on the y-axis is weight for length, and on the x-axis is looking at rainfall data in these different areas of the world. And so you can see that wasting is happening when there's really heavy rains. And so one kind of clear explanation for this is tying it to food security and when people are having to do kind of peak agricultural work. But also I think, there might be a role for infectious disease here and pathogens, like when there's flooding, there's probably increased transmission of pathogens when there's heavy rainfall. And so this kind of intro is motivating our work in this session for looking at pathogens and exposure pathways. So we also know that nutrition interventions are effective, but they're really unable to fully solve stunting and wasting. There's been a lot of meta-analyses recently looking at lipid-based nutrients supplements, and they've been very effective, but they're just not able to really push children into not having growth deficits. Okay, we also know that enteric pathogen infection is extremely common in these settings. This is one of my favorite figures from the GEM study showing that enteric pathogen prevalence is very, very high, even in kids that don't have diarrhea. So you're looking at, in red, children that have diarrhea, in blue, children that don't have diarrhea, and you see we see almost very similar pathogen infection prevalence in both types of kids. All right, we also know that there's multiple exposure pathways that kids are getting exposed to these pathogens through. There's been a lot of work looking at fecal indicator bacteria and trying to understand exposure pathways. And I think that work has really shown us that there's some very understudied pathways that haven't been given a lot of attention, like soil, hands, food, flies. I think the fecal indicator bacteria work has really shown us that those pathways are important, and It's also kind of hinted at animal feces being a really important exposure pathway too, but we can't really fully unpack that without looking at specific pathogens and trying to trace transmission from animals to humans. Okay, and so we also know that pathogens behave very, very differently than fecal indicator bacteria. And so it's really exciting now, I think, in the field that we have all these new methods like TACMAN array cards, sequencing, molecular methods, digital PCR, that can really look for specific pathogens and do actually high throughput analysis to look for 48 pathogens at a time. And so without further ado, I'm going to kind of plug Abby's presentation, who's going to come up and talk about some work where we were looking at exposure pathways in rural Kenya. I think this is the first time this work is being presented today that's actually including the longitudinal data that we have. So we were able to look at exposure pathways and then subsequent child infection and new child infections, because we were looking at kids that were quite young. And so I'll turn it over to Abby. This is some work that was done in collaboration with a very large international team. KEMRI, the Nwiri project was an amazing partner, and I'll turn it over to Abby.
Okay. Great, thanks Amy. And I apologize if I stumble over my words or anything, because I don't think my coffee has hit me yet, as I'm sure is true for many of you. So yeah, as Amy said, I'm presenting about a study we did in rural Kenya. And so this is in a region of northern Kenya, in Turkana and Samburu sub-counties, and this is a really rural, low-income setting, largely pastoralist or agro-pastoral, so there's a really high livestock ownership. Some community members travel seasonally with their livestock as well for search of grazing land and water. There's also really poor access to improved WASH in this setting. For example, less than 5% of households have access to improved sanitation. And some surveys have also found that there's high rates of gastrointestinal illness and global acute malnutrition in children in this setting. And so our research question for this study was to think about how are children under 2 in these regions exposed to enteric pathogens, and which specific pathogens are they exposed to. So to kind of look at this question, we used a mixed methods approach where we enrolled 100 households that each had a child under 2, and we did a range of different activities in each household. So we collected a range of different sample types, including environmental samples, water, soil, hand rinses, food, rinse from fomites or toys that children had been mouthing. And then we also collected both child and caregiver stool and animal feces. We also did such structured observations in a subset of households where for 3 hours we would observe our target child and observe everything that they touched or put into their mouth, for example. And then we also did a range of household surveys trying to understand child health and WASH status. And so for all of these different sample types that we collected, we used a form of qPCR, the TACMAN array card, to detect the presence of 33 different enteric pathogens. And then another thing I want to note that Amy already mentioned briefly is that we did longitudinal monitoring for those youngest children, those under 12 months, and this consisted of 3 to 4 visits, 7 days apart. So I want to just dive right into talking about our pathogen results. So we have presented here all of the different pathogen results. So on the x-axis is the sample types that we measured pathogens in, and the y-axis is a list of all these specific pathogens. I apologize if this is small to read. And then the color corresponds to the proportion of samples of that type positive for that pathogen. And so to kind of pull out 2 of our key results is that, first of all, we found a really high prevalence of a lot of these human enteric pathogens in animal feces, and especially within poultry and dogs. And then we also found that over 80% of the children in this setting were infected with at least one of these pathogens, the most common of which were enteroaggregative E. coli, enterovirus, enteropathogenic E. coli, Giardia, and adenovirus. And then another thing I want to note is that we also looked at the pathogen burden by child age group. So we've pulled it out into children between 0 and 2 months, 3 to 5 months, 6 to 11, and 12 to 24. And we can see how many pathogens and which pathogens children are infected with by age. And so we find that the pathogen burden increases with child age. but that even by the time children are 3 months, they're typically infected with 1 enteric pathogen. By the time they're 24 months, typically infected with 5. And another thing to note is that in our surveys, we found high diarrheal prevalence across all of these age groups. And so using our longitudinal data, we were also able to identify new infections in children. So even with a kind of limited study size, we identified 67 new infections in these children under 12 months from 18 different enteric pathogens. And we also found that detecting a pathogen in either animal feces or soil was associated with subsequent new infection in children with that same pathogen 7 days later, suggesting that both animal feces and soil could be important pathways or contributors in this environment. And so just to kind of pull out our key results, we were able to detect a range of enteric pathogen infections and new infections specifically in children under 6 months, even though when we did our structure observations, we saw that these children had really limited contact with a lot of common environmental pathways, suggesting that interventions need to really limit exposure to children in this age group and kind of think specifically for this age group in terms of how to prevent transmission. We also find, as I said, that animal feces and soil contained a wide range of enteric pathogens, and so developing culturally appropriate animal fecal management practices will be really important. So yeah, I don't know who's next, but.
Thank you, Abby. Hello, everyone. I'm Alazar, implementation lead for the whole hygiene household research in rural Ethiopia. So this is a proposed implementation research being led by World Vision and WASHPaLS. And several studies have shown that there is no silver bullet intervention in terms of disrupting multiple exposure pathways to diverse enteric pathogens. So we need a transformative approach. And that's what we are trying to do with the SPEAR2 project and with a set of interventions in a randomized control trial. So the SPEAR2 project is is deemed ideal because its lifespan extends until 2026, and it's a resilience food security activity project, a RIFSA, funded by USAID's Bureau of Humanitarian Assistance and supporting the implementation of the 5th phase of Ethiopia's Productive Safety Net program. So we work in Amhara and Oromia regions. World Vision leads the implementation and in partnership with CARE and ORDA. So our study location is in West and Eastern Hargeisa, some 300 miles from the capital Addis, and it's in Oromia region. And we are targeting rural households with pregnant women and who reside in these PSNP households. And there's a subcomponent of the PSNP households called the temporary direct support, where pregnant women and lactating mothers are registered to be exempted from public works. So the design is a 2-arm randomized controlled trial where we observe, where we foresee a comparison between households receiving integrated package, shown on the middle, and as compared to the control group. We will also use a realist evaluation framework to analyze mixed methods data to identify why selected interventions have observed impacts through qualitative methods, and we will also be using quantitative methods to identify the relative impacts and strengths of causal pathways that affect outcomes. We will also be deploying cost-benefit analysis of the interventions. So the study team will collect data through community households, surveys, observations, and environmental and fecal pathogen testing. And we will also deploy intent to treat ITT analysis to utilize data collected through fecal pathogens to test and determine overall intervention effectiveness. Meanwhile, the released evaluation will use data obtained from household surveys and structural observations, as well as the environmental sampling for enteric pathogens. So this is a brief plan that we are going to embark on until 2026, and we'll be happy to collaborate with additional stakeholders as we seek more funding towards the implementation. Thank you.
Thank you, Alizar. All right. And next we have Food for the Hungry. Thank you.
Hello, everyone. I'm Stuart Goodwin. I'm the WASH manager with Food for the Hungry. I'm representing our Food for the Hungry Ethiopia team. I want to present about our baby wash study. This is part of also a resilient food security activity funded by USAID. And RTI has also been a partner of this project, doing the research, the CLA. And so I'm going to be presenting entitled Playpens +4. So the 5 key behaviors for reducing child pathogen exposure in Amhara of Ethiopia. So last year, Food for the Hungry did a formative research looking at what are the key behaviors and what are the factors as attributing to affecting children under 2 years old. Because in rural Ethiopia, there's lots of feces, dirty objects that infants are often exploring their environment, and it's common for them to put things in their mouth. And so, as you saw in the previous F diagram, a lot of interventions have been done around hand washing, water quality, sanitation, but we felt like there hasn't been a clear intervention separating dirty objects and animal feces from the infants and young children. And so what we are piloting as part of this study is establishing a safe play space with either a play mat or a play pen as our key intervention. And we found that you really need to integrate any one intervention with multiple others. And so we are also prioritizing safe disposal of human feces, hand washing with soap at critical times for caregivers, children under 2, safe handling of drinking water, and the collection, transport, and treatment, and pinning of small animals. And so, yeah, the playpens we found in the study, and then we also did a feasibility study where we actually met with the community to really understand, is this something even feasible? And we found that they were open to playpens, and that it was common to use a kind of a surface, a play mat, for infants already. And so there's a number of benefits for mothers, caregivers, to have a safe place that allow children to be. And the hope is really that by having that intervention, it would kind of encourage caregivers to prioritize these other key behaviors as well. So to walk through a little bit of our implementation process, I mentioned the formative research study, then a feasibility assessment, and then we actually held a co-creation workshop with the community, assessing, kind of giving training on how to build a playpen, because we didn't want to, I guess, give the materials. It's very much built around our care group model. So doing like cascade groups where we selected 120 households over 2 woredas of Ethiopia, that we would train them on these, there's I think a total of 11 behaviors, including these 5 priority And then, so yeah, identifying 120 caregivers, training women health development armies, WHDA. That's like the volunteer women leaders, community health workers in Ethiopia. And so they're kind of our main target that then spreads the message to other communities. And so the monitoring evaluation, we developed a tool to really do kind of bi-weekly household level check-ins to determine how often these behaviors were being practiced, and to then really evaluate what behaviors were adopted and what were not. And unfortunately, you'll see there at the end, this M&E and scale-up phases are still pending due to security situation in Amhara currently. We're in the middle of I think we've established 60 of the households so far to do the care group teaching and training, but we don't have any key results, unfortunately, to share with you. But this is our hope that we would be able to monitor and find kind of a reduced microbial load, in these children and infants. And our plan is to scale this up throughout other areas and to really institutionalize it and to get government support as well. It's really the key. And then finally, these are just some of the results. Like I said, we hope to have improved child nutrition, reduced exposure to pathogens and feces, and that playpens would ultimately have a positive impact on the other evidence-based approaches. Thank you.
Thank you so much for that. All right, following that, we have Kandwani.
Right, thanks very much. So I am Kondwan, and I'm working with Malawi University of Business and Applied Sciences. And the work I'm to present here is part of a study, a larger study, which we conducted under the SHARE Consortium, where I worked with a number of colleagues, including Tracer, we see as well, trying to find interventions that may help to improve child health and well-being at household level in Malawi. Yeah. So this study was conducted at household level in Malawi, and specifically it was in southern part of the country where that's Aquaya district, where households are not connected to the national grid electricity, but also access to safe water mainly is through boreholes. And this study was conducted because previous interventions, they focused much on the nutrition specific, but what we were trying to do now is to bring in the element of WASH specific as well, or nutrition sensitive interventions to improve the child and well-being in these settings. I should say that what we did formative research, we designed an intervention, and then we tried the intervention. But what I'm presenting to you today will focus much on the formative research, just to lay a background of what are some of the issues that may need to be considered if we are to develop an intervention in this context. So one of the things that we noted is mother is the primary caregiver, but it requires male involvement. So if we are to come up with interventions, then the father should not be left out, because the father is key in decision making. For example, we are talking of providing for resources like soap. But also there's homogeneity diet, that's what we noted. We may have an understanding that children are maybe only given porridge, but they will eat together with the whole family, okay? Maybe during morning, lunch, and even dinner, they eat together. So there's no separate food to say this is for the child, and maybe this is for the parents. So when we want to come up with interventions, that's really something important to be considered. but also availability of caregivers. At household level, you may not only have one caregiver. We have the mother, of course, but we also have siblings. We have aunts, we have grandfathers, grandmothers that also they are taking care of the child. So an intervention may need to consider all these other important aspects. Unfortunately, we noted limited capacity of healthcare workers and community volunteers to really handle all these issues. And the animals, people have already talked about animals involved in disease transmission. And this is not excluded in this context. And one thing that I've not included here, but we may also need to take into consideration, which we found were issues of norms in the society. As we are saying, there are a number of caregivers, they're living together, sharing information and all that. So norms do influence behaviors in these settings. And importantly, poverty acts as a barrier of all. So in designing an intervention, this should be taken into consideration, something that is really context specific, looking at the economic situation of this kind of a setting. So in our study, we came up with the, we conducted a HACCP, we used the HACCP approach just to identify the critical control points, and we focused on the food that is given to the children. So what we have on the far end there is the process that is involved in preparing porridge for the child, and the other part here, we're trying to identify the critical control points, and then while preparing food for the child and the rest of the family, maybe lunch or dinner. So in a summary, I should say that what we mainly identified as critical control points were to do with feeding the children after the food has been prepared, the processes that are involved, very critical. Storage of food, maybe storage of leftover food, but also reheating of the food. Is it adequately reheated? Those are the issues that we were looking at. And importantly, cooling of the food, the cooling process, maybe food being left uncovered while in the cooling process, and then maybe cooking is an important critical control point, but you find that during cooling process, the food may be decontaminated. So these are the key issues that we identified. I should say that having looked at this, we are to carry out a study which gives us an opportunity to validate what we identified in our previous studies. So we are collaborating with FHI and the other partners, including World Vision, in WASHPaLS 2, where we'll carry out a study in 2 phases, the formative research to validate what we found previously, but also to design an intervention that can be applicable to this context. And then phase 2, it will be a feasibility study to confirm or test the intervention that we have developed. Thank you very much. So this is what I just wanted to highlight to you in relation to the work that we have done previously and what we are planning to do ahead of us. So we have this QR code, which we may need to scan because we need to be participatory. It's not like we're in a church. If you're in a church, you don't really participate. You just listen to the preacher, but let's take part in this process. So can we scan this QR code, and then we move on with our program? Okay. I'm sure we are all together on that one. So you may need to share with us other examples of recent or ongoing attempts to explore the effectiveness and feasibility of individual or collective hygienic environment interventions. So it's open to us maybe to share what we have done, our experiences, but also how can we work together to ensure that we improve interventions in these settings that are really having a number of challenges as far as child health is concerned. Okay, so there's an issue of, I learned about animal process.
maybe it blocked out animal feces, but a more colorful term for animal feces.
I wrote feces, so I'm shocked that censored feces. I feel like this is like proof of the stigma around sanitation.
I mean, all this is really good as from a chipmunk.
Okay, it's true. I checked feces, I confirmed it, she's not lying.
Yeah.
Poop also gets censored?
Okay.
I am writing to the company.
They write sanitation.
Yeah. There's an issue of excreta. Yeah. Yeah, this is so interesting. Talking of using long handle caps to fetch water from water containers. Yeah, because as we are trying to draw water from the container, as this is very common in rural settings in low-income countries, that's also a point of contamination as well, because someone may end up dipping the whole hand into the water. So how can we make an improvement on that? There's a suggestion of using a long arm when drawing water at this point in time. So all these are really important aspects that may need to be taken into consideration. But also there's an issue of nighttime cooking of poultry separated from the household living space. As you know, in these settings, we live with our animals in the house during the night for security reasons, okay? So, but how can we ensure that that is not bringing in contamination? Because sometimes where you're keeping the animals is where also you are keeping your food utensils, okay? Maybe, how can we do that? There was a suggestion in one of the sessions that we may need to come up with maybe those animal houses outside, just maybe far away from the house, or some meters from the house. But how effective is this? Consider looking at the issue of safety, okay? So you may want to do that, but is it practical in these settings? So how can we handle animals to make sure that it's not they are not a source of contamination? From the previous slides that we have seen from other presenters, this is really an important issue. So very important in these settings. All right. Let's move on. So we have heard from a number of presenters. I think it's quite important that we can also hear your views, but also questions as well that can spark discussion in this area. So let me maybe pause here for questions. If you have a question, you can line up on the microphone, and then let's hear from you. You can ask any presenter who has presented previously, not only me.
All right, thanks for these presentations, really interesting, and I like how concise they were and how much we could learn in a very short time. So I'm curious about a paper that I teach on to civil and environmental engineers is 2005 Cutler and Miller about the impact of drinking water quality and supply interventions on infant mortality and child mortality in the U.S. And it seems like the findings are robust. I don't know the kind of demographic methods, but for those who are doing all this, household hygiene stuff, how compatible are those findings with what you're finding in these various settings? I know it's a big question. I'm just very curious about it, because that paper, like I tell civil and environmental engineers, you're not really taught, but we had a massive impact on health and development of ecological transition. So yeah, I'd love to hear perspectives on that.
Ami?
Yeah, sure.
Yeah?
Yeah, so Greg was my advisor at Stanford during my PhD, and I think that for the
Yeah.
people online.
Yeah, so that paper I think is a really important paper. And we didn't really get to dig into the formative research and kind of the qualitative research that we did with the communities where we did this pathogen study. But when we presented the results to them, one of their biggest reactions was, we need better water infrastructure in our communities. We need to be able to access safe water in our settings. So that's what they want. And I think that we're never going to get to a hygienic environment without laying the infrastructure down first. And so I think it's really important that when we talk about transformative WASH, we're thinking about how we can put the infrastructure in first, and then think about what are the interventions that need to layer on top of that.
Because that was my thinking about how they're compatible, but I just wanted to check with all of you, because I don't, I haven't read deeply into research that you're presenting.
More questions? Yeah.
Sorry, Amy, but another one for you. You alluded to this a little bit on the pathogens are not E. coli bit, but I'm wondering if you could say a little more about where we're at on trusting E. coli results or their utility, and then methods for pathogen detection instead.
Yeah, I love talking about fecal indicator bacteria. So, I mean, I think we've seen again and again that fecal indicator bacteria don't actually correlate well with actual pathogens in environmental matrices. And, I mean, the only strong association I've seen is like E. coli correlating with pathogenic E. coli. So that's kind of an obvious one. I mean, I think fecal indicator bacteria are still super, super useful for understanding performance of treatment technologies, for understanding the presence of the likely presence of fecal contamination, not as useful for understanding where children are getting exposed to specific pathogens. And so that's why, we were really excited to roll out using the TAC card to really understand where pathogens are coming from and where their sources are. And so I think now that we have these tools, we're kind of just on the cusp of using them to better understand also what types of interventions are needed, because pathogens are going to be, they're going to be susceptible to different types of interventions. So for example, for chlorination, it's not going to reduce Giardia and crypto and protozoa, but it's going to be very effective against bacteria and viruses. So yeah, that's my 2 cents.
Thank you to all the presenters, these really exciting projects getting started. I'd actually like to hear a little bit more about the plans for the playpens and these very multifaceted interventions, and specifically coming back to the point of just how many caregivers there can be in these children's lives, and how you will engage all of them, and what you've heard so far about caregivers' willingness to use playpens, and how that kind of how you can strike the right balance between working within people's normal practices and yet also overcoming some of the exposure pathways there, because behavior change is very hard, and yet to some degree it might be exactly what's required. So I'd love to hear a little bit more about that from those two guys.
Yeah, maybe you can start, Michael. Yeah. While he's coming, let me remind our colleagues who have joined online, please feel free to throw your questions or comments, and then we can also share with the audience here.
Yeah, thanks for the question. Yeah, the playpens, we assessed the feasibility along with the other options, and because the pinning of animals we thought would be the best idea, but as was mentioned, people were actually kind of against that. Some like pin chickens, but they were more opposed to pinning their animals, all throughout the day and night than the idea of a play mat or play space. And then we looked at community playgrounds. Would it make sense to have like one location for multiple children, but actually caregivers said that was more of a burden because someone would have to kind of monitor that space. So it really at the household level was what community members felt like was the best idea. But there's not a lot of research on play pens alone as an intervention, but we're hopeful, yeah.
Yeah, I think in the interest of time, we need to move on, but we can just hear if you have a question, another question? Okay, I thought it's a hand. Okay, so maybe we should move on with our session. Let's hear from another presenter about part 2 of this session. Hand over to Gretchen.
Yes.
Yeah.
Actually, we'll have Aquaya who's going to have Valor.
Great, thanks. So I'm Valerie Bauza with Aquaya, and I'll be presenting the research component of a study that was done in Madagascar for identifying and interrupting fecal oral pathogens in children under 2 in the southeastern area of Madagascar. And I'll be presenting this research component on behalf of my colleague Chloe Poenlin, who actually led this research work in Madagascar, and then I'll be passing it over to ADRA to discuss all the implementation related components of the work and how the results were fed into implementation. So we heard a lot about why fecal pathogens are important and their contributions to things. So I won't go into a lot of the details on the slide for the background. I'll just focus specifically on Madagascar. And so that was a focus because there's a high prevalence of enteric pathogens and stunting in mortality within Madagascar, and specifically within study areas that we use. So this was part of FIOVANA, which is a 5-year USAID BHA-funded project that aims to achieve sustainable improvement in food and nutrition security, as well as resilience of vulnerable populations in Southeast Madagascar. And it was focused on the 3 regions that are highlighted on the slide, particularly because WASH access is very low in those regions. So 66% practicing open defecation, and only 4% have access to safe drinking water and practice good hand washing behaviors with soap. The research study had 2 main research questions that were investigated. So the first question was trying to understand what the main pathways of fecal pathogens are for children under 2 within these implementation areas. And this was investigated through field work that was broken down into 2 phases. The first phase included collecting more detailed information from 35 households through household surveys and these more detailed, longer structured observation periods of 2 to 4 hours, observing children's behaviors and all the potential exposures within the household environment, and then doing some E. coli sampling, followed by a second phase of fieldwork with a larger number of households that also had a household survey, but instead of this longer structured observation, focused on shorter spot check observations for some key exposures, and then combined some of the E. coli fecal indicator bacteria sampling with pathogen sampling along some of these key pathways. And then all of that information was fed into a QMRA analysis to try to understand the actual risk of infection and illness from some of these different pathways. And then the second research question really focused on implementation and trying to understand what interventions could potentially interrupt these transmission pathways once they had been investigated from the first part of the work. So for this study, out of the different transmission pathways, 4 were focused on, including drinking water, soil, hands, and food. And within those pathways, like I said, we investigated E. coli and pathogens for the environmental compartment, and there were 6 pathogens that were measured that are listed on the slide. And then within the households where pathogens were investigated, children and animal feces was also collected, and pathogens were measured within those feces as well. So this slide summarizes the results of the pathogen analysis, and for this analysis, 26 of the households tried to have all of these environmental compartments and feces sampled and measured, although not all households had all of the compartments, so that's why there's slightly different numbers. For some of the sample type, like almost no households fed raw food to children under 2, so there's very few samples that were able to be measured, for example, for raw food. But to interpret this graph, like it shows the prevalence of the different types of pathogens in the compartments, and the gray shows the prevalence of any of the 6 pathogens, and then the other colors show the individual pathogens. And I think there's a few things that sort of stand out in these results. First, we saw a higher prevalence of pathogens in the animal feces compared to children feces, and different types of pathogens. So the animal feces was mostly poultry and cows, and so as expected, there were higher prevalences of pathogens like Campylobacter and Shigella, but in children, the primary pathogens were Giardia, adenovirus, and then a bit of Campylobacter. So it seems like a lot of that exposure to things like Giardia and adenovirus may be coming from the drinking water pathway in this setting, and then exposure to Campylobacter and animal feces might be contaminating the soil, getting on children's hands, and then exposure through those pathways, so you can kind of see, how the different pathogen profiles like link to the environmental compartments. And then we also did the E. coli analysis, and as expected, it's not a perfect overlap with the pathogen analysis. And so this shows different levels of E. coli in the different environmental compartments, where red is the highest levels of E. coli and green was no E. coli identified. And we see the highest levels of E. coli in, say, drinking water, in soil, but high levels kind of across all of the compartments. So it's not like all of the compartments seem important. So then when we take all this information on contamination in the different compartments and do a QMRA assessment to combine this with exposure information, so how much drinking water are children consuming, what level of soil are they ingesting, how many hand-to-mouth contacts do they have any day, we can understand the dose of exposure from the different pathways. And so that's what this graph shows. So essentially this shows the quantity of E. coli ingested per day from each of these 4 pathways for different aged children in our group, based on those observations of their activities and the contamination that was measured. And we can see that for children 0 to 6, most of the pathways aren't important, and their level of exposure overall is pretty low in this specific setting. But when we look at children 7 to 12 and 13 to 24, all 4 pathways are pretty important for their exposure. Except for the children 7 to 12 months, cooked food is slightly less important because children are still breastfeeding. And in the 13 to 24 months, direct soil ingestion is a bit less common, so that pathway is slightly less important than some of the other pathways, though children still have a lot of hand-to-mouth contact, and their hands are likely contaminated with the soil. So, it's sort of, we see that it's important to address really all of these pathways in this population. And so I'm going to pass it over to my colleague Yves at ADRA to sort of talk about, what did they do with this information and what are the recommendations from it from an intervention and implementation standpoint.
Thank you, Valeria. Good morning, all. I'm Yves Rasloufier. I work with Adventist Development Agency, a relief agency at Madagascar. First of all, as I come from a French-speaking country, please excuse my English. As presented in this slide, several recommendations were given. These recommendations are classified according to the pathogen transmission routes, which chosen 4 pathways: drinking water, soil ingestion, hand-to-mouth contact, and cooked food. We moved from recommendation to practice. As following follow-up of this research, an extensive awareness-raising campaign was carried out as part of project with specific aims. First, FUVAN has made project aware of the importance of pathogen transmission factors and the effects on children's health and growth. FUVAN leveraged existing social network like mothers-to-mothers group, communication channel, and trust relationship with lead mothers within the community to disseminate the information and encourage peer for change. Secondly, FUVAN involved the community and stakeholders in finding feasible solutions to improve the situation. Third, FUVAN has developed and promoted a co-creation approach to sanitation, which is a CLTS adaptation to encourage the participants to think about their health situation and find solutions adapted to their context, economic, social, and cultural, while stimulated the self-regulation and self-help system. Also, FUVAN is working closely with traditional authorities who are essential to the success or the failure of all social activities in the community. There were some challenges. Project participants are extremely vulnerable people with a very low incomes and education. There are some taboos and cultural barriers which made the classical CLTS unsuccessful. These regions are periodically exposed to hazards, cyclone, drought, as well as insecurity problems. So, in 2021, FUVAN had opted for a series of 5 life-stage family scorecards covering pregnancy through the child's 5th birthday. These have now been adapted, include key pathogen reduction action at diverse stages of a child growth. We can see 4 stage family scorecard for 1 to 5 months, 6 to 11 months, 12 to 23 months, and at the beginning for pregnancy. Parents appreciate that Peer for Change asked for each life stage is of the same order as the previous one, small, doable action. They are iterative, no downtime, no need to remobilize family, virtually 100% of family continues from one stage to the next. There are integration with pathogen transmission interruption to 0 to 5 months, focus on to-move transmission with father's involvement in household core, particularly in wash task, for example, and washing, so women can have sufficient time to breastfeeding and caregiving. For 6 to 11 months, still focus on hand-to-mouth transmission and on use of clean utensils for baby feeding. For 12 to 23 months, focus on cooked foods. To reduce pathogen ingestion from chilled muffin, this aspect of pathogen ingestion has traditionally neglected in WASH intervention. FUFAN introduced maths utilization in the life stage family scorecards. Making indigenous maths made from local material is an ancestral practice in this region. Women and girls are highly skilled in making these mats, so they are available and affordable. They come in all sizes depending on use. Vandabanan, a small size for eating, tsi, ulafk, large size for sleeping, sitting, or playing. The challenge lies in the durability and cleanliness of this mat, with limited access to swab, disinfectant, to clean the mats regularly. FUFAN focused awareness raising on the use of these play mats by children and their caregivers in all daily activity. We also take some lesson from this study. First, fecal pathogen exposure is a complex and multifaceted problem that requires a holistic and integrated approach to WASH intervention. Simply providing access to improved water source, sanitation facility, and hygiene practices may not be sufficient to reduce the risk of diarrheal disease and stenting in young children. Secondly, young children are particularly vulnerable to fecal transmission pathogen exposure due to their frequent contact with contaminated environment, such as soil, animal feces, vomit, and food. These exposure pathways are often overlooked or underestimated in conventional WASH intervention that focus only on water quality, sanitation access, and hand washing with swab. We are presented with an opportunity to supplement interventions such as breastfeeding and infant and young child feeding promotion alongside WASH intervention to collectively reduce the susceptibility to infection from fecal pathogen. Last thing, intervention must comprehensively address source of environmental contamination through multisectorial intervention, which also consider the associated impact on livelihood, dietary diversity, caretaker stamps demand, etc. Thank you.
Great, thank you so much. Let's see. My name is Nicole Weber, and I'm the WASH Technical Director for USAID Bureau for Humanitarian Assistance funded project ProWASH and Scale. And so we work with partners on capacity strengthening, learning, and research. And so as a segue, that was a very nice segue. Eve mentioned the need for monitoring and evaluating those transformative interventions. With Aquaya and Fiovana, we worked on the previous research, and now the goal really is for us to support partners to use some of those findings. And I think that's a theme throughout the week is how do we translate evidence into practice. And so part of this work, my colleague Steve Serra, who is on paternity leave, so he's not here today, worked with Aquaya to develop a quick guide for partners on planning and data collection. So this guide was developed by Aquaya, really based out of the research and work that they did with Fiovana in Madagascar, and we also appreciated a lot of inputs from partners, including some of you in the room today. So this guide really is to provide implementing partners with a menu of data collection tools and methods that you might want to use to monitor those transformative WASH interventions. So the guide helps you determine whether or not you need to conduct mixed methods formative research to identify and prioritize fecal oral pathways for infants and young childs in your implementation geography, or if you can rely on existing evidence. And it also provides a menu on how to design formative research activities to identify and to prioritize the ingestion pathways of fecal pathogens, both human and animal, for infants and young children. The guide provides a menu both for formative research, but then also of suggestions for indicators you can use and methods that you can use throughout the implementation process. So there's a QR code, you can download it. It's also available in French, and we'd welcome any feedback you might have on the guide. The guide really takes you through 4 steps, starting with what do we already know, collecting global, national, regional information on that would be relevant for your project. So always starting with that, and then what are the info gaps? The next step is to design and conduct formative research to fill in any of those gaps and to be able to design your interventions. And then the third one is to look at what methods you might want to incorporate into your monitoring and evaluation plan. And so the guide really tries to balance what is technically necessary to look at in monitoring, but also what is really feasible in terms of in this guide specifically, it's looking at multi-sectoral food security interventions that are typically about 5-year projects. So there's a menu there. It talks about using surveys, observations, qualitative methods, and then there are some recommendations around environmental sampling and using laboratories. But again, each partner has to balance what's feasible in their context with their resources. This is also as I noted, the guidance that's available. Oh, the list I just said, quantitative survey methods, qualitative observational methods, and then environmental and feces sampling. So we're really interested to see, and to start looking at how partners are monitoring some of the interventions that are based on the pathogen pathway research. So I think now we can transition into questions and discussion on part 2. And we invite you again to join us on AHA Slides. We have another question that we'd love to get your input on, and then we'll have some questions for Fiovana and Aquaya, but also if you have other questions from today's session, we'd welcome taking those. Let's see, I can see 13 people have joined us so far. After this session, I'm going to go back to AHA Slides and test like every single word in sanitation and, and see what's acceptable and not. Oh, there we go. So our first question we have is, have we reached a saturation point within the literature that demonstrates the environmental hygiene risks to infants and young children? There's a little bit of anticipation as the results are hidden. So we have 6 yes, 13 no, and 4 I don't know. So maybe I can invite Konwani, would you like to maybe comment on the findings and thoughts from your perspective as well?
Yeah, thanks very much. So just looking at this question, I think it's a complicated issue. Should we say that we have reached a saturation whereby we have enough literature to demonstrate environmental hygiene risks? I should say that from what we have seen so far in this conference, but also from other sources, we may not conclude that we have reached maybe a saturation because we still need more evidence. For example, we may need to validate the findings that we have at the moment, okay? So that requires further exploration. But also, we may have studies that are being conducted in different contexts. So because they're being conducted in different contexts, we may not just take what has been applied in A and assuming it will work in B. So that may require further exploration. But also, we may want to carry out longitudinal studies. We may want to try interventions for a long time and to see how effective they are, which requires still further exploration. But also from what we have seen from the recent COVID-19 pandemic, we have seen how the variant kept on changing, and it requires further exploration. But also recently, maybe some 4 years ago, 5 years ago, we had the WASH benefit study, the SHINE studies. The results were a bit, there were a number of variations on those results. It wasn't really more positive on the interventions that were implemented to reduce child exposure to these pathogens. So looking at all these, it requires transformative kind of research, but it requires stronger collaboration among players, different players from different backgrounds, maybe to respond to this question. That's why maybe we're saying, no, we still need more of this. Yeah, thank you.
Great, thank you so much. Any other thoughts or observations or on this question specifically? See some hearts, okay. Yeah, please.
I mean, in order to answer that, we now know there are literature who often talks about the pathways. The pathways being food, water, and soil, flow, all of this. I think we do have a lot of information. Where we are lacking is what sort of behaviors and intervention that we can apply that will actually block those transmission routes at a scale.
Mm-hmm.
So lots of small scale intervention has seen to be proven to be effective because of intensive resources, intensive focus, but when it comes to scaling up those small scale project type behaviors and intervention, we haven't seen much on this.
Mm-hmm.
Of course, I work waterway, we have tried a couple of countries. In one country, we're now doing the national scale intervention, also including the exclusive breastfeeding, the food hygiene, the hand hygiene, and so forth. We have seen some level of contamination has reduced, the behavior has improved, but it's still. So what are those critical pathways that we really can address to block maybe 70% of the pathogen? I think what we need is more on operational research where we can really demonstrate what are those proof of concept interventions that we can apply to block those transmissions.
Mm-hmm. Yeah, great.
That's what I say.
Yeah, great, thank you. Do you want, Gretchen, I see you cheering. Do you want to add anything? Or that's.
Just an emphatic agreement. So.
Yeah, yeah. And I think some of the work that WASHPaLS is planning specifically is on that intervention piece. Yes?
I think I was just going to build on that point a bit that I think in my view, coming out of like what I said, the WASH benefit in China, what those trials show is that it's very, very difficult to interrupt the overall transmission for children. And some of these interventions that are being piloted, like playpens and trying to separate children from contaminated environments, it's very, very hard, particularly when children become more active and now we are getting more everywhere, better assays to test for different pathogens that children are being exposed to. I think that's a step in the right direction, and I think we need more of that, figuring out where they're coming from, how, and exposures in children. And I was just thinking when the two presentations that, where they were talking about how exposure to pathogens was increasing with ages, and I'm thinking, we're thinking through different interventions. Are there any households, maybe I don't know what the sample size looks like, where you didn't see any exposures in these children? Maybe we need to start there and look at the characteristics of those households, where after the assays you see, the hand rinses for children are actually not contaminated. People better for kids are not contaminated. What are they doing right? Maybe we need to go back there and figure out interventions from their perspective, what they're already doing, what are they doing right in those, and I think like a deep dive and figure out what's going right in those households and try to replicate in the rest of the communities.
Okay. Okay, great, thank you for that. And I'm just going to quickly summarize because people online haven't been able to hear the conversation. So just to say, we heard from a colleague from WaterAid back here that there's a need for more research on what interventions work to interrupt pathogen transmission. And so that's where he's recommending that a lot of the research efforts focus is on the implementation and looking at what's feasible. And I think I heard that echoed in your comment as well around, especially a lot of these interventions require behavior change, and it's very difficult to keep babies on play mats or away from some of these exposures. And then you asked, did you come across any households that didn't have any exposure? So maybe that question would be for Abby and Amy. Were there households in the study where there was no exposure or very little exposure? Yeah, and yes, the microphone, please, so they can hear us online.
Yeah, I mean, I think it's a great idea. I love that suggestion. I think, unfortunately, we have kind of a small sample size, only 100 households in this study. But I think we can say that pathogens were everywhere, and especially on child's hands. These are really young children. What % of children had Giardia on their hands? Abby, do you remember?
I think
40% of kids have Giardia on their hands. I mean, how can you, hands I think are a really great indicator of environmental contamination. And so how can we interrupt that level of exposure? It's really hard. It's really hard. And I think it goes back to needing to really think about how can we invest in working with governments and professional service providers to provide better services in these settings. And once we're there, then thinking about what are the right behavior change interventions we need to be later on top.
Mm-hmm. Yeah, great, thank you. Over Tracy, do you want to go ahead and then, yeah. Yes, please, yeah.
It's very awkward, isn't it? No, I was just going to absolutely 100% agree with everything everyone else has said, but I think one of the gaps we still have in that kind of what we need to look at in pathways are public spaces. I think we haven't done enough on that. A lot of under-twos spend time in early childhood development centres, other places, they go to markets, they get other exposures with their mothers, and we're not really looking at that at the moment where they're picking those up, so a lot of the focus has been on household. So expanding into that space a bit more effectively.
Yeah, that's a good segue to a quick question, by me, and that is, I was involved in household water treatment and safe storage back when it became kind of big in 2005 or so, and then there were these two papers in 2012, 2013, Brown and Clausen and Enger et al., that showed that if your compliance or adherence to your household water treatment intervention wasn't close to like 95% plus, that it had almost no effect on actual health. And I can't remember who presented the QMRA stuff with the dose response. Yeah, I think, I mean, I hate to say it, but like you have to be really comprehensive about eliminating pathogens from the environment and from other environments where people take kids. If you're really going to take them from either the upslope or the plateau on the dose response down to the bottom. Sorry. Because I stopped working in HWTS after those papers because it convinced me that it wasn't probably going to work.
Okay.
that like really quick community level interventions are really important.
Yes. Ask for it.
Thank you. This is better, thank you. So I'd like to throw in an interesting one. So two things here. The first one is that, I mean, as mothers, we are told that exposure to pathogens for a child who's growing is good for their immune system to grow. I guess the question is, how much? And I don't know if research can establish that, and if there is some threshold or some level of exposure we should be talking about. The second thing is that risk perception amongst the communities where we're working in, amongst those women, is very low. They've been there, they've done that, they've raised other children in the same environments, and the children are doing well. So how do we convince them that moving forward you need to stop this or reduce the level of exposure? Because these are the realities. The people we're talking about, they're rational, they think. The other thing is the women that we work with, particularly in these reef says, they're busy women. They do not spend the day at home seated and watching children playing in playpens. They have to go to the fields, they have to go to the market, they have to look for food to eat on a daily basis. So as we're doing all this work, I think we need to really have this at the back of our minds, because I think that's where behavior change becomes complicated, because what we're trying to do may not necessarily be practical in the environments and the context that we're trying to intervene.
Thank you. I'm a zoonotic infectious disease person, so being at the WASH interface makes a lot of sense. And so all of the work to bring in the animal feces and the animal exposures is just critical. But I think something I'm not hearing is the importance of the human-animal bond when we're thinking about interventions. And so just kind of remembering, because I personally have a dog and a cat in my house. And when we're talking about interventions, about excluding these very important parts of our world or our culture or our home, it kind of gets a little bit prickly. So I don't think that there's like a great answer for this, but when we're thinking about interventions to reduce exposure, thinking about it from that lens of that critically important human-animal bond that is just inexplicable.
Yeah. Great. Maybe to Delilah's point and your point as well, any thoughts from speakers?
Just one at the point on what she has said. She has raised an important point in terms of the context where these interventions are happening. So maybe one thing that we may want to really look into is the context itself. Yesterday there was a session about HCD, human-centered design approach. I think those are the approaches that needs to be strengthened, because we're talking of a caregiver who is very busy at this particular household, moving up and down. But how can we track this particular caregiver down to intervene, to take part in the intervention process? So that's really something very important. Much as we have all these, but how can we ensure that whatever intervention we're doing is really being integrated on the household daily activities? That's something very crucial. Yeah.
And Delilah, who asked the question, was a panelist yesterday on the HCD. So curious to also hear more thoughts from you after about how do we overcome some of the challenges. And I appreciate your point about the animal-human bond. And within the multi-sectoral food security activities, we've also talked a lot about, animals are a form of livelihoods as well. And so what are those interventions look like that take into account all of these different facets that are just beyond health and WASH, but the husbandry, the livelihoods, and then those relationships as well. So thanks for bringing that up. I think we have time for about one more question. Thank you. And thank you so much for volunteering to move the mic around.
Yes, thanks for not making me get up. Hi, everyone. Josh, UNC, Chapel Hill, nutrition. I think also a lot about water security and the multiple water sources that people are using. So a lot of the time we are measuring drinking water, and I'm wondering about multi-water use, how this intersects with hygiene and thinking about, people experiencing also intermittency. So there's one preferred source, but what happens when that goes out? So just thinking if there's any examination beyond just drinking water quality.
Looking at multiple sources of water? Are you going to be looking at multiple sources of water use, not just drinking sources of drinking water?
Yeah, so definitely we'll be looking into multiple sources because households use another source of water for food preparation kinds of stuff. So yeah, certainly that's needed really to check that.
I would just say it's a really important issue, and I think intermittent supply also places a huge burden on the household when they have to go switch their source and usually walk further to collect water, and that usually falls on the women.
Great, thank you. And thanks so much to everyone for the questions. If you would like to connect with us and stay engaged on this topic, you're welcome to add your email address. I want to take a minute to just really thank all of our presenters who came together today. This is a joint event co-convened by WASHPaLS 2 and with FHI 360 and ProWash and Scale, but we really appreciate all of the organizations that put in a lot of time to share your research and your proposed interventions with us and with the crowd. I've heard very strongly that there's a lot of evidence that is out there, but also a lot of gaps that there still are, and so I hope that we can continue this conversation and identify opportunities to continue to work together, especially making the links between researchers and implementers. So I think the next slide you'll see here, we have put additional resources on a website so that you can access some of the study reports, like the Aquaya report, the one from Kenya as well, and some work from WASHPaLS as well as others. There's also the quick guide to formative research that I mentioned. So with that, I'd like to thank everyone and wish you a happy Friday and safe travels back to where you came from. Thanks.